Newborn, healthy and complications. So, as pediatric is not simply internal medicine applied to children, so neonatology is not simply pediatrics applied to the newborn. It's very different from general pediatrics, and in some hospitals, like ours, it's even structured in an independent ward from the pediatric one, because it requires specific specialties and trainings, especially for the care of unhealthy newborns. Neonatology is a very broad subject, but due to time limitations, we will cover only very general aspects and few pathological conditions. A newborn can be defined as healthy or unhealthy based on three parameters: gestational age, weight, and Apgar score. Gestational age, it's easiest to define by careful history of the mother and the pregnancy course score. So a term is defined as between 37 as born between 37 and 42 weeks and preterm before 37 weeks. Weight. The absolute weight must be correlated to the gestational age following specific curves. We can have adequate for gestational age when it's in the 10th, 19th percentile, small for gestational age, less than the 10th percentile, and large for gestational age, more than the 90th percentile. The Apgar score is very useful and simple prognostic indicator of newborn's health status. So healthy newborn. Healthy newborn is defined by a term gestational age, adequate weight for gestational age, Apgar score more than 7. So a term, adequate weight, and Apgar score more than 7. Specific curves to check parameters relatively to gestational age are present for weight, length, and the dead circumference. Adequate for gestational age, general values in the healthy newborns are body weight between 3,200 and 3,500 grams, length between 50 and 54 centimeters, head circumference between 32 and 36 centimeters, respiratory rate between 30 and 50 per minute. The heart rate is between 150 and 160 per minute. It must be at least more than 100 beats per minute to define a healthy newborn. Apgar score is a composite score evaluated at 1 and 5 minutes after delivery. In cases of problems or pathological results, it must be re-evaluated also at 10 minutes. A score of 7-10 is considered normal. A score of 4-7 is considered at risk. And neonates with a score less than 3 are at high risk and require immediate intervention. Parameters to be evaluated are appropriate skin color, so healthy newborn is completely pink. If it is bluish or pale, so complete cyanosis indicates an unhealthy condition which requires immediate intervention. Acrocyanosis, which you see in the image, is a quite frequent finding, particularly at 1 minute evaluation, and is not especially associated to a bad prognosis. So acrocyanosis is not that bad. Quite frequent, not particularly associated to a bad prognosis. The pulse, so the heart rate for a normal newborn must be above 100 beats per minute. Grimace. We have a reflex irritability upon nose suction, one of the first maneuvers done on the newborn to clean the nose from any material that could cause breathing problems. We have activity, so muscle tone, active motion, and respiration with respiratory rate of 30 per minute or more. The newborn is healthy. So the score is appropriate skin color, 0 if blue pale, 1 if acrocyanosis, and 2 completely pink. Pulse, heart rate, absent if 0, less than 1 if less than 100 beats per minute, and 2 if more than 100 beats per minute. Grimace, that is reflex irritability at nose suction, 0 if no response, 1 if grimace, and 2 if cough or sneeze. Activity, muscle tone, we have 0 if limp, 1 if there is some flexion of extremities, and 2 if there is active motion. Respiratory effort if it's 0 if it's absent or irregular, 1 if it's slow or crying, and 2 if it's good. Shortly after the APGAR score evaluation, a quick initial physical exam should be performed. After delivery, if the child seems overall fine, she is immediately given to the mother for an initial skin-to-skin contact, then is taken under a special light for warmth, APGAR scoring, and a quick general evaluation. So we check for if there are no major abnormalities, no birth injuries. Tongue and body appear pink. Overall evaluation of skin and mucosa and patency of nose, ears, anus, and urethra. Confirmation of genitalia. We have to listen also to heart and lungs. Examine the eyes and oral cavity directly. Vitamin K and antibiotic eye drops administration for prophylaxis. And clinical observation and cleaning. You have to favor mother-child interaction. It's very important because it favors breastfeeding. You have to stimulate breastfeeding. We have a physiological weight loss after birth must be less than 10 less or equal to 10-12%. In the following 24 hours, it's very important to do a complete physical exam, so to check for vital signs, physical exam, neurological exam, assess of archaic reflexes, and estimation of gestational age. The neonatal physiological events are weight loss, maximum 10%. The weight loss is normally due to the fact that the child begins to eliminate both urine and feces. Each should stop around the second or third day of life, and anyway, it should never be more than 10%. If a child loses more than 10% of his original weight, the breast milk alimentation must be supplemented with some formula because it is insufficient by itself for the nutritional requirements of the baby. We have meconium passage within 24-48 hours. This is the first feces. We have a first urine around 15 milliliters. We have caput succedaneum. That is must be in differential diagnosis with cephalematoma. We have physiologic jaundice and genital crisis also, which is a hyperplasia of the breast of an infant with estrinization of vaginal mucosa and sometimes vaginal bleeding under the influence of transplacentally acquired estrogens. We have transient dermatosis and archaic reflexes. We have also non-healthy newborn, which is a newborn can be considered non-healthy based on 3 parameters: gestational age, non-adequate weight, or APGAR score less than 7. This means the child either has a pathology or she is at increased risk for some complications. So we have a premature newborn, which is a premature baby, is an increased risk for complications. The risk is proportional to the degree of prematurity. We can have slight prematurity between 34 and 36 weeks, intermediate prematurity between 32 and 34 weeks, and severe prematurity less than 32 weeks. Also, body weight is an important factor in determining the risk of these newborns. The more severe the prematurity, the lower the weight, and the lower the weight, the higher the risk. So we can classify babies in extremely low body weight, less than 1 kilogram, very low body weight between 1 and 1.5 kilogram, and low body weight between 150, 1.5 and 2.5 kilograms. 1.5 and 2.5. The main risks of a premature child are those associated to immaturity of one or more organ systems: lungs, immune system, GI tract, CNS, eye. This lead to complications due to dysfunction of the system involved. You can have fetal suffering, which can be acute or chronic. Asphyxia, inefficient thermoregulation, increased infection risk, lung dysmaturity, immunological dysmaturity, intestinal dysmaturity, CNS dysmaturity, retinal dysmaturity. Prematurity risks are SLI between 34 and 36. We can have hypoglycemia, hypocalcemia, feeding difficulties. If it's between 32 34, so intermediate prematurity, we can have hypoglycemia, hypocalcemia, feeding difficulties, and also primary and secondary apnea, respiratory distress, and infections. If the prematurity is severe, that is less than 32 weeks, the risks are metabolic complications, asphyxia, hypothermia, cerebral hemorrhages, pericentricular leukomalacia, respiratory distress, and sepsis. So, we can define a child as small for gestational age. They can be further divided into symmetric. If a circumference, length, and weight all less than 10 percentile, there are 33% of small for gestational age infants. The causes are infection, chromosomal abnormalities, inborn errors of metabolism, smoking, and drugs. Asymmetric, the weight is less than the 10th percentile, head circumference and length are normal. They are 55% of small for gestational age infants. The causes are ultraplacental insufficiency, chronic hypertension or disease, preeclampsia, hemoglobinopathies, altitude, placental infarcts, or clonic abruption. Can be combined, so symmetric or asymmetric. There are 12% of small for gestational age infants. The causes are smoking, drugs, placental infarcts, or chronic abruption, filamentous insertion, circumvallate placenta, and multiple gestation. Small for gestational age associated risks are metabolic complications, reduced tropism, chromosomal abnormalities. So we have to do a genetic counseling and karyotyping that could be useful, and dysmorphisms. To be large for gestational age, the main cause for large for gestational age babies is a disease of the mother, especially diabetes. Large for gestational age associated risks are obstetric trauma, metabolic complications. 3. Apgar score less than 7. An Apgar score between 7 and 4 is associated with an increased risk of complications and worse prognosis. A score less than 3 requires immediate reanimation and neonatal resuscitation. So, obstetric traumas, mostly associated to large for gestational age newborns. You can have cephalohematoma, it is actually not a very serious condition. It's an hemorrhage between the skull and the periosteum of a newborn, secondary to rupture of blood vessels crossing the periosteum. Its boundaries are limited by the individual bones. The usual causes of cephalohematoma are prolonged second stage of labor or instrumental delivery. If severe, the child may develop jaundice, so progressive lysis of entrapped cells, anemia, or hypotension due to physical sequestration of blood to the site. In some rare cases, it may be an indication of a linear skull fracture or may be at risk of an infection leading to osteomyelitis or meningitis. The swelling of a cephalohematoma takes weeks, even up to a month, to resolve, but it does not require any specific intervention. You can have brachial palsy. It's the incidence of brachial palsy, plexus palsy, is reported to affect 1 per 1,500 live births. Most commonly on the right side, because the most frequent delivery presentation of the baby is left occiput anterior vertex. It can be associated with pre and gestational diabetes, older maternal age, increased body weight, and large for gestational age. It's caused by stretch tear, compression or avulsion of the nerves, usually after a forceful lateral deviation of the head from the shoulders during delivery. Recent studies suggest intrinsic forces as uterine contractions may contribute to the pathogenesis. Newborn with brachial palsy injuries have a higher incidence of low Apgar scores of less than 7 at 1 and 5 minutes and of asphyxia than matched controls. Clinical manifestations are asymmetric motor reflex, Erb's palsy caused by the disruption of the upper brachial plexus, so posture and adduction of and inward rotation of the shoulders with extension and pronation at the elbow and flexion of the fingers. It's a position called waiter's tip. Can have also Klumpke's palsy, which is absent grasp of the hand. This is usually a benign condition which resolves spontaneously in most cases, but it must be differentiated from more severe pathologies like cervical injury, cervical spine injury, dislocation of upper extremity, fractures of the upper extremity, and intrauterine maladaptation palsy. Subrachial palsy is usually a benign condition. Management. The majority of patients with brachial plexus palsy at birth will recover completely and spontaneously from neurologic deficit, 1-2 weeks of rest of affected limb. Early referral to upper extremity clinic and physiotherapy if not already resolved. Caregivers should be instructed on how to handle the baby, no traction of affected arm, no pressure under axilla. Those who do not recover during 3-6 months period require surgical intervention, but this is an extremely rare condition. Can have respiratory distress and RDS. In general, in the newborn, it's extremely difficult to identify diseases and pathologies based on signs and symptoms because they tend to be extremely aspecific or even silent. Among these, respiratory impairment is easier to identify because it has some characteristic signs. The signs of respiratory distress are tachypnea, respiratory rate less than 60 times per minute, beats 60 per minute, chest retraction, so need of to use accessory muscles for breathing, and grunting, so leading to impaired air passage. The majority of respiratory distress cases are caused by pulmonary causes, so respiratory distress syndrome is the most common. Meconium aspiration syndrome, pneumonia, transient tachypnea of newborn, pneumothorax, upper airway obstruction. Some can be caused by non-pulmonary causes, which must be excluded before any intervention is done, so cardiac metabolic, as hypoglycemia or metabolic acidosis, and CNS, like asphyxia and cerebral edema. Respiratory distress syndrome. Acute respiratory distress syndrome, also known as hyaline membrane disease, is an acute lung disease of the newborn caused by pulmonary surfactant deficiency. It's more frequent in neonates younger than 32 weeks of gestational age. Incidence, increasing incidence with decreasing gestational age. So, less than 28 weeks is 60-80%. Between 32 and 34 weeks is between 15 and 30%, and at 37 weeks is 5%. This increase in incidence with prematurity is because surfactant production starts at 20 weeks of life and peaks at 35 weeks of gestation. So any neonate less than 35 weeks is prone to develop RDS. Infants of diabetic mother have a 5 to 6 times higher risk of respiratory distress syndrome than non-infants of diabetic mothers. The etiologies are prematurity, pulmonary surfactant deficiency. In fact, the functions of pulmonary surfactant are to lower surface tension, maintain alveolar stability, and prevent the collapse of small air spaces at end expiration. In the absence of surfactant, we have surface tension which increases. The alveoli tends to collapse during expiration. During inspiration, more negative pressure is needed, the workload increases, there is inadequate oxygen plus increased work of breathing. Hypoxemia and acidosis, pulmonary artery constriction, right-to-left shunting across foramen ovale, which worsens hypoxemia and eventually leads to respiratory failure. Clinical manifestations are symptoms: progressive respiratory distress within 2-6 hours, tachypnea, intermittent expiratory grunting, from partial closure of the glottis. Signs are nasal flaring, subcostal and intercostal retractions, cyanosis, hypothermia. X-ray are ground glass change, so fine reticular granularity of the parenchyma. Laboratory exams are the measurement of the levels of pulmonary surfactant is very interesting but difficult to do and so not really used in clinical practice. The main test performed is blood gas analysis, so partial arterial oxygen pressure measured on a arterial blood gas machine, oxygen dissolved in plasma, and so the main test performed is blood gas analysis to measure the arterial oxygen pressure and percent oxygen saturation, measured by pulse oximetry. Management. General management is temperature maintenance at 36.5 degrees, monitoring respiratory rate, heart rate, saturation of oxygen and blood gas, adequate fluid support, and electrolyte supplement. Start feeding if stable, consider parenteral nutrition, correction of acidosis, antibiotics, diuretics, and anti-inflammatory. Oxygen, oxygen therapy and assisted ventilation with nasal cannula, mask, or head box oxygen. CPAP, continuous positive airway pressure to prevent alveolar collapse at end expiration. Best possible therapy, minimally invasive and effective. If necessary, positioning of an endotracheal tube and, at this point, start replacement therapy via endotracheal tube within 2 hours of life, 2 4 doses. This must be done so pulmonary surfactant replacement therapy via endotracheal tube within within 2 hours of life. This must be done immediately after birth if the child is severely premature and with high risk of developing RDS. Oxygen therapy must be continued for as long as it is necessary, from few days to even months in very premature newborns, but the response is highly variable. This may cause some side effects, as the retinopathy of the premature, linked to excessive oxygen intake, so they have to be carefully balanced with the risk of hypoxemia. Prevention of prematurity managed by the gynecologist. You have antenatal or corticosteroid therapy. The outcome of respiratory distress syndrome has improved with the increased use of antenatal steroids and early postnatal surfactant therapy. Asphyxia. Asphyxia is another complication. Hypoxic ischemic encephalopathy is a brain injury caused by oxygen deprivation to the brain, usually during delivery. For this reason, it is also commonly known as intrapartum asphyxia. Not all cases of intrapartum asphyxia result in frank encephalopathy with clinical consequences. It often leads to severe developmental or cognitive delays or motor impairments that become more apparent as the child continues to develop. Usually, the severity of impairment cannot be determined until a child is 3 to 4 years old. Hypoxic ischemic encephalopathy is one of the most commonly recognized causes of cerebral palsy, 6.23%. The incidence of intrapartum asphyxia is about 3-4 per 1,000 live births. The incidence of hypoxic ischemic encephalopathy in the absence of other preconception or antepartum abnormalities is approximately 1.6 per 1,000 live births, so around one half of all asphyxia cases. Moderate or severe hypoxic ischemic encephalopathy is burdened with a mortality rate between 10 and 60%. Among the survivors, 25% develop neurologic sequelae. The fetal brain is protected from hypoxia during birth. More demand and less supply by 3 mechanisms: cerebral vasodilation, use of alternative substrates like lactate and ketones, and increased affinity for oxygen or of fetal heart hemoglobin. For these reasons, hypoxic insult is destructive only if severe and protracted, although there is still a lot of clinical variability due to unpredictable individual susceptibility factors. Neuropathology of asphyxia in newborns. The first damage to neurons occurs in the absence of oxygen with a primary event of necrosis. A second damage is caused by reperfusion and the new arrival of new oxygen, together with free radicals formation and inflammation, thus causing secondary neuronal apoptosis. The clinical interpretation of these events is quite complicated, especially the evaluation of prognosis, because, depending on when and how severe the event of asphyxia was, the damage and outcome can be extremely different. You can see here, first insult is due to anaerobic metabolism, lower energy production and accumulation of lactate. Then secondary neuronal insult can be due to the arrival of oxygen with production of oxygen-free radicals, inflammation, and loss of autoregulation of cerebral blood flow. We have a 6 hour of latency between the two episodes. So, hypoxic ischemic encephalopathy is most common in full-term infants, although it does occur in premature infants as well. The timing and severity of asphyxia can affect the area of the brain that sustains the injury. If injury occurs before week 35 in fetal development, hypoxic ischemic encephalopathy is likely to produce periventricular leukomalacia or PVL, so damage to white matter around the ventricles. At 40 weeks, the degree of hypoxia correlates to the area of the brain that is injured. Mild hypoxia will affect the parasagittal white matter, while severe hypoxia affects the putamen, thalamus, and paracentral white matter. The area of the brain that is affected will have a significant bearing on symptoms the child experiences. The events that lead to asphyxia include, but are not limited to, acute maternal hypertension, hypotension, blood containing less oxygen due to poorly functioning lungs, cardiac complications, injury from cephalopelvic disproportion, injury from umbilical cord complications, impaired blood flow to the brain during birth, interruption in breathing or poor oxygen supply, intrapartum hemorrhage, medical negligence, prolapsed cord, placental abruption, pressure to the cranium that changes its shape, resulting in bleeding or decreased blood flow, ruptured vasa previa, stress of labor and delivery, trauma, uterine rupture. The asphyxia brain damage criteria to attribute a cerebral framework to intrapartum asphyxia: metabolic acidosis, pH less than 7, and detected on umbilical cord, artery, or newborn, with detected on umbilical cord, artery, or newborn within 1 hour from birth. Encephalopathy less than 24 hours from the birth in newborns of more than 34 weeks, spastic or dyskinetic tetraplegia, and no other plausible causes, like metabolic conditions. Treatment for hypoxic ischemic encephalopathy focuses on helping the child adapt to symptoms that result from the brain injury, so supporting therapy. Physical and occupational therapies are commonly utilized to treat cerebral palsy caused by hypoxic ischemic encephalopathy. Asphyxia typically causes permanent damage, which sometimes continues to progress even after the asphyxia has been relieved. To prevent further damage, the child must be medically monitored to maintain normal blood glucose, maintain normal blood pressure, prevent or control seizures, prevent or minimize cerebral edema secondary to the lesion. A new therapeutic intervention is the hypothermic treatment. This brain cooling. Hypothermia is an effective therapy in a selected population of newborns with moderate or severe hypoxic ischemic encephalopathy. The treatment has begun prior to 6 hours of life. The methods of hypothermic treatments are essentially two: systemic hypothermia and selective hypothermia. They yield almost superimposable results. Some recent studies show an apparent improvement of prognosis in children treated with this therapy with lower burden of disease in the short term, with less motor damage and better cognitive development. However, it's a relatively recent technique and there are few data available still. Currently, hypothermia is the chosen treatment to stop the pathologic processes in the brain, reducing intra alia the vasogenic edema, the release of excitatory neurotransmitters and oxygen-free radicals, the activation of cytokines, and the brain metabolism. The brain protection depends on the temperature and time delay between insult and beginning of treatment. More effective with cooling to 35 plus or minus degrees and less than 6 hours after hypoxic ischemic insult. Eligibility criteria only apply to infants of gestational age of more than 36 weeks, but criteria A and B must be present. Intrapartum hypoxia defined by at least one of the following criteria: Apgar score less than 5 to 10 minutes of life, need to continue intensive care with endotracheal tube or face mask and bolt for up to 10 minutes of life. Fetal or neonatal acidosis defined as pH less than 7 or um, BE more than 16 millimoles per liter for any exam obtained in the first 60 minutes of life. Nota bene, the sample must be taken as soon as possible, preferably from umbilical artery. In the case of more than a arterial blood gas in the first 60 minutes of life, consider the one with more pathological values. Second criteria is moderate or severe hypoxic ischemic encephalopathy according to the classification of Sarnat and Sarnat, evaluated between 30 and 60 minutes of life. Evaluation of neurological status. At least 3 abnormalities are required to classify an infant in a specific stage of Sarnat. Sarnat 1, hyperalert, normal tone and motility, normal or exaggerated motor, normal and reactive pupils. Sarnat 2, lethargy, reduced motility, hypotonia, reduced primitive reflexes, so prehension and sucking, meiosis, bradycardia, periodic breathing. Sarna 3, stupor or coma, decerebrate posture, limbs extensors hypertonicity, absent spontaneous motility, flaccidity, absent reflexes, mydriasis or reactive pupils, and apnea. Clinical evidence of exposure to hypoxic ischemic perinatal encephalopathy are either an Apgar score less than 5 at 10 minutes, or metabolic acidosis with a pH less than 7, or BE more than 60, more or equal 16 millimoles per liter, plus altered neurologic examination, CERNAT 2 and 3, between 30 and 60 minutes of life. Infections and sepsis. Another relevant pathologic condition in the newborn is represented by infections and sepsis. A number of factors, mostly related to the general conditions of the mother, influence the baby's risk to develop infections. It can have maternal temperature if the mother has fever during delivery, protracted ruptures of membranes, leading to long-lasting labor if more than 18 hours antibiotic prophylaxis is required. Mother with vaginal or rectal swab. Strep B positive. Group B streptococci are one of the major causes of sepsis in the newborn. UTI in pregnancies, maternal viral or parasitic infectious disease, so vertical transmission, stained amniotic fluid, the newborn could aspirate some fluid thus developing pneumonia, neonatal sepsis in previous pregnancies. Most cases of neonatal infections become sepsis, which can be defined with temporal classification, early or late. Etiological classification, beta hemolytic Streptococcus group B is the most frequent one. E. coli, Listeria monocytogenes. Clinical manifestations are signs and symptoms could be extremely difficult to interpret. Can have none. Some cases are completely asymptomatic until some complications arise. Apnea, crisis of cyanosis, hypoglycemia, hypothermia, hyperthermia, respiratory distress, jaundice, and septic shock. Therapy of a newborn with clinical and laboratory evidence of sepsis is, while waiting for culture results, Empirical with ampicillin 10 milligrams per kilogram per day in 2-3 doses plus gentamicin 5 milligrams per kilogram per day 1 dose intravenous. Group B Streptococcus is a gram-positive coccus, causes the majority of neonatal infections, 1-3 per 1,000 live births, because up to one-third of women are colonized with reservoir of infections in the intestine and reproductive system. It can give both early and late upset disease. The latter is highly associated with meningitis, so it's extremely important to act promptly to stop regression and more severe sequelae. Risk factors for early neonatal GBS infection are previous infant with GBS systemic infection, GBS bacteriuria during the current pregnancy, protracted rupture of membranes more or equal 18 hours, maternal temperature during labor more than or equal 13 degrees, chorioamnionitis, low maternal serum levels of anti-GBS antibodies, and prematurity. Intrapartum antibiotic prophylaxis can lead to administration of active antibiotics against group B streptococcus, such as to obtain concentrations of effective drugs in amniotic fluid. It is given in pregnancies considered at risk following the 1996 guidelines for the prevention of perinatal group B streptococcus, which caused a reduction in the incidence of early neonatal group B streptococcus of approximately 70%. In 2002 and 2010, there was a revision of the guidelines, which underlined the fact that the best preventive strategy is based on the universal screening in pregnancy. Assessing the GBS status of the mother, screening carried out or not, positive or negative for group B streptococcus. Assess actual need for intrapartum antibiotic prophylaxis based on vaginal or rectal culture positive for group B streptococcus in the 5 weeks prior to birth, or positive urine culture in the current pregnancy with the exception of elective C-section without labor and with wall membranes. Previous anamnestic of another child with neonatal GBS sepsis, unknown GBS status at the moment of birth, and suspected chorioamnionitis, temperature more than 38 degrees, labor and birth less than 37 weeks, rupture of membranes more than 18 hours. Intrapartum antibiotic prophylaxis is considered adequate if one of the following antibiotic schemes has begun at least 4 hours before birth. Can have penicillin IV, 5 million units initial dose, then 3 million units every 4 hours until birth. Ampicillin V, 2 grams initial dose, then 1 gram every 4 hours. If penicillin allergy, cefazolin IV, 2 grams initial dose, then 1 gram every 8 hours. Please note that any other antibiotic scheme used must be considered inadequate. Metabolic complications. There are a number of metabolic complications that can occur in a neonate, and many pathological conditions of the newborn are associated with metabolic alterations, including inadequate for gestational age, weight, prematurity, or low Apgar score. You can have neonatal hypoglycemia, which can be transient or persistent, hypocalcemia, which can be transient or persistent, hypomagnesemia, polycythemia, and jaundice. Neonatal jaundice is a yellowish discoloration of the skin and sclera due to increasing bilirubin serous levels. About 50% of at-term healthy newborns present with physiological jaundice due to accumulation of conjugated bilirubin. Conjugated bilirubin is usually below 15% of total. Bilirubin levels generally peak on day 3 to 5 of life in babies and day 5 to 6 in preterm babies. It becomes clinically evident jaundice when bilirubin is more than 5-7 mg per deciliter. First, it manifests on the face and then on the trunk and the extremities, with craniocaudal progression. Bilirubin is insoluble in water and must be placed into the plasma circulation bound to albumin. In the liver, bilirubin is changed to a water-soluble compound by conjugation by the enzyme reading diphosphoglucurosine transferase. Conjugated bilirubin is released from the liver into the bile duct and then to the GI tract for elimination. Some bilirubin is also excreted through the urine by similar processes. Small amounts of unconjugated bilirubin are not bound to albumin, but circulate as free bilirubin. This unbound insoluble bilirubin crosses the lipid-containing cell membranes, including the blood-brain barrier, and if in excess, it is toxic and can cause kernicterus, which is a bilirubin-associated encephalopathy with death of glial cells and neurons. The mechanisms of toxicity are yet unclear, but the damage is proportional to the levels of serum uri unconjugated bilirubin, and is greater the younger is the child. Unconjugated bilirubin is lipophilic and crosses the blood-brain barrier. Blood-brain barrier of infants is more permeable than adults, and acidosis causes it to be even more permeable. Conjugated bilirubin has an affinity for the basal ganglia, hippocampus, cranial nerve nuclei. Mechanism is widely studied but still unknown. Unconjugated bilirubin interrupts metabolism in glial cells and causes apoptosis of newborn neurons. Exact mechanisms are unknown but definitely separate pathways. The age of the cell is inversely proportional to susceptibility. Neonatal jaundice, so physiological or non-physiological, direct bilirubin or indirect bilirubin, hemolytic or non-hemolytic, and early or late. Physiologic neonatal jaundice. Jaundice is almost universally observed in all neonates due to larger red blood cell mass, shorter red blood cell lifespan, so increased hemolysis, greater amount of bilirubin produced from sources other than red blood cells, increased enterohepatic absorption and circulation, defective conjugation and plasmatic clearance, decreased hepatocellular excretion. Pathological jaundice. Jaundice is not physiological when it is clinically noted in the first 24 hours of life. The increase of bilirubin is more than 5 mg per day. Bilirubin is more than 12 mg per deciliter in preterm and more than 15 mg per deciliter in full-term newborns. Direct bilirubin is more than 1.52 mg per deciliter. Pathophysiology of exaggerated hyperbilirubinemia. We have polycythemia, hemolysis, Rh incompatibility, ABO incompatibility, abnormal red blood cells, glucose 6-phosphate dehydrogenase, cytosis, thalassemia, birth trauma, so bruising, cephalohematoma, metabolic abnormalities, Crigler-Najjar-Joubert syndrome, galactosemia. Medications, so sulfonamides, which displace bilirubin from albumin because they have the same binding site. Differential diagnosis, minimum evaluation of hematocrit and reticulocytes. Low hematocrit and high reticulocytes, they are due to medicines, enzymes, and or membrane defects. Low hematocrit or equal and increase in reticulocytes or equal or increase in reticulocytes, it means a systemic bacterial or viral infection. The hematocrit is equal or unmodified, and the reticulocytes are equal. It's physiological, breastfeeding, metabolic, something else. The hematocrit is increased and red blood cells and reticulocytes are increased or equal, we have a polycythemia. Treatment. Physiologic jaundice, no treatment is needed. Phototherapy is more than 10 mg per deciliter between 0 and 24 hours, between 15 and 17 milligrams per deciliter between 24 and 48 hours, and more than 17 milligrams per deciliter at more than 48 hours. Phototherapy mechanism of action can have photoisomerization in the extravascular cutaneous compartment, consists of transformation of bilirubin in less toxic polar compound that diffuses in blood and is excreted without the need for conjugation. The photoisomer, however, is rapidly converted in the intestine to unconjugated bilirubin that could recirculate into blood. Structural isomerization leads to the formation of lumirubin that is rapidly eliminated by the liver and kidneys. Structural isomerization is irreversible. Photooxidation leads to transformation of bilirubin into products with low molecular weight excreted in the urine. Optimal phototherapy is expose as much skin as possible. Eye patches, except for feeding, turn frequently. Monitor temperature, monitor intake and output of fluids. Increasing sensible water loss is common. Monitor for diarrhea. Side effects appear only if long-lasting treatment and not sufficient support is given. Loose stools, diarrhea, dehydration, hyperhypothermia, skin rashes, and lethargy. IV immunoglobulins leads to administration at high doses was proved to be like 500 1000 milligrams in single or repeat administration for 3 days was proven to be able to reduce the levels of bilirubin in units with AB0 or anti-D isoimmunization in the case of insufficient response to phototherapy. The mechanism of action is not entirely clear, probably a saturation of the receptor for the Fc fragment of reticular endothelial cells, and therefore the block of capture and lysis process of sensitized red cells. Can have inhibitors of heme oxygenase. Dimethylporphyrin are synthetic analogs of heme that inhibit the HO activity, thus reducing the production of bilirubin. The block of the heme catabolism doesn't involve accumulation in the tissues of this compound, which is excreted as such in the liver without the need of glycuroconjugation. The thin mesoporphyrin, only drug approved for clinical use by the FDA, administered as a single dose by injection, reveals its activity for about 7-10 days and has proven its extreme effectiveness in randomized and controlled trials, even in cases of isoimmunization, reducing significantly the need for phototherapy and exchange transfusion. Side effects are increased incidence of transient photosensitivity rashes in case of concomitant phototherapy. Exchange transfusions, guidelines for exchange transfusion in infants 35 or more weeks gestation. Immediate exchange transfusion is recommended if infants show signs of acute bilirubin encephalopathy or if total bilirubin is more than 5 or equal 5 milligrams per deciliter above these lines. Risk factors include isoimmunohemolytic disease, glucose 6-phosphate dehydrogenase deficiency, asphyxia, significant lethargy, temperature instability, sepsis, acidosis. Can have also hepatic maturation induction and surgery eventually. This also, to repeat the treatments, physiologic jaundice, no treatment needed. Then we can use phototherapy, IV immunoglobulins at high doses, inhibitors of heme oxygenase, exchange transfusion, hepatic maturation induction, and surgery. Jaundice during breastfeeding. It appears in the first days of life in infants exclusively breastfed and is mainly due to inadequate nutritional intake. Pathogenesis, increase of enterohepatic circulation of bilirubin associated to low intestinal transit and slow colonization by germs that normally convert conjugated bilirubin to urobilinoids. It cannot be attacked by the intestinal beta-glucuronidase and therefore are not absorbable. The caloric deprivation also acts as inducer of heme oxygenase. Therapy is implementation of breastfeeding and possible integration with adaptive formula. And have also jaundice from breast milk. It occurs in 2-4% of term infants exclusively and successfully breastfed. After the 4th-5th day of life, bilirubin continues to increase, being able to reach around the end of the 2nd week of life also values of 30 milligrams per deciliter, with the risk of kernicterus. Even in the absence of measures, bilirubin then tends to decline gradually, reaching normal values between the 4th and the 12th week. Suspension of breast milk for the 36-48 hours leads to rapid decline of serum bilirubin that, at the resumption of breastfeeding, can go back to 2-4 milligrams, but no longer reaches the high initial values. It's not completely clarified pathogenesis. Excluded an inhibition of UDPG linked to the presence in the milk of high levels of 3-alpha 20 beta preganadiol or non-esterified fatty acids, resulting from excessive lipase activity. The most likely hypothesis is an increase in the enterohepatic circulation of bilirubin that does not seem secondary to excessive content of beta-glucuronidase but to unidentified factors. It is possible the role of genetic interactions.